Yeah. My first, next talk is surgical outcome of the iris claw lens in complicated cataracts. Now, how should we deal with the PCR in cases of manual small incision cataract surgery? So we should first see whether there is real PCR or not. Whenever we are in dilemma, we should confirm it with the triamcinolone acetonide injection into the intracameral site. If there is a PCR, then we should look for the status of the nucleus. If there is a nucleus drop, then we should suture the wound, counsel the patient, and refer it to the VR surgeon. If the nucleus is intact, then gentle viscoexpression of the nucleus is to be done. After that, we have to analyze the size and the location of the PCR. Then we can we should tamponade the PC tear with cohesive viscoelastic, cortex aspiration, and anterior vitrectomy is to be done. Then we should analyze the sulcus if it is intact or it is compromised. Now, now we have to analyze the situation aphakia with the open posterior capsule. So if the sulcus is intact, then we can go ahead and implant the 3-piece IOL and do optic capture if possible. If there is the anterior capsular rim is not intact, then there are 4 options. We can implant a 3-piece IOL, but there are chances of subluxation or dislocation. We can also fix iris claw lenses. We can implant AC IOL, and scleral fixation is also an option. Now, how to decide which lens to be implanted in cases of compromised sulcus? So we should see whether the patient has good visual outcome, with good potential of the visual acuity, and whether patient can tolerate spectacles and contact lens. If the patient has normal iris, then we can go ahead and implant retropupillary iris claw lens. In these patients, it is important to do regular follow-ups. Then if the iris is absent or it is damaged, then we can go ahead and implant scleral sutured IOLs with Prolene 9O suture, and iris reconstructions can be done. If patient has any uveitis, uncontrolled glaucoma, inability to follow up, then surgeries are contraindication in these patients. Why should we choose retropupillary iris claw lenses? Because technically they are very less challenging. There is short learning curve. It protects corneal endothelial cells, protects iridocorneal angle, and the secondary glaucoma is very less likely, and the rate of dislocation is less. Now, what are the possible complications with the retropupillary iris claw lenses? There are iris chaffing and chronic inflammation can be there. Pupillary distortions, cystoid macular edema, poor dilatation of the pupil can occur after implantation. So before implanting iris claw lens, we should make sure that there is no vitreous in the pupillary plane. We should stain it with the triamcinolone acetonide. IOL power is to be adjusted before implanting. Then optic is well centralized. Both the haptics should be fixed, and peripheral iridectomy should be done at the last. So how to implant retropupillary iris claw lens? We have to make one side port opposite to the previous side port. We have to inject pilocarpine in the anterior chamber and align the optic centrally, then tuck one haptic, then tuck other haptic in the same plane. At the last, we should do peripheral iridectomy. Now we conducted one study of surgical outcome of the retropupillary iris claw lens in manual small incision cataract surgery. The purpose was to analyze the visual outcome and complications following retropupillary fixated iris claw intraocular lenses. So it was a retrospective study, non-comparative. We reviewed 74 patients who underwent primary retropupillary iris claw implantation for correction of the surgical aphakia. It was conducted during the period of December 2021 to 2023, and it had a minimum post-operative. We followed up for 2 months, and we checked post-operative best corrected visual acuity and intraocular pressures, and complications were noted. So these were our results. We saw 86.48% of patients showing more than 6/9 visual acuity, and only two patients had almost 3% of visual acuity less than 6/60. 3 patients developed secondary glaucoma. 4 patients had cystoid macular edema. 5 patients had to undergo resurgery for one optic subluxation. All patients had good pupillary dilatation. Only 1 patient had corneal decompensation, and 1 patient had retinal detachment. So this was the patient with 1 haptic dislocation. We had to do resurgery for this patient. This was the commonest complication we encountered. Finally, the conclusion. So I would like to conclude with the retropupillary iris claw IOL provides good visual rehabilitation with fewer complications. Ease of insertion and short surgical time makes it a good option to correct aphakia in patients with inadequate capsular support. And thank you.
Thank you so much, Dr. Soniya, for wonderful presentation. The complicated cataract you have made very easy. So we'll be taking questions in the end of the session. I would like to ask Dr. Kanchanbala Rathod to present a clinical and surgical profile of cataract surgery in pseudo-exfoliation eyes. And the second topic of her is surgery for posterior lentiginous cataract.